good afternoon, everyone. Thank you so much for joining me today as I talk about Parkinson's disease. So, as my title suggests, Parkinson's disease is more than just a tremor. So, we'll spend the next hour explaining why I say this. So, just briefly, what a movement disorder specialist is, you might wonder what that term means. I am a neurologist who's done her neurology residency. Then I take extra time, about 1 to 2 years, to train more in Parkinson's disease. So, let's get started. I have nothing to disclose related to the talk. So, first question: what does Parkinson's mean to you? And so I ask this for patients who first come into our clinic, have the new diagnosis, and ask them, what do they know about Parkinson's? And these are the most common words that I hear: tremors, shaking, Michael J. Fox, shuffling, trouble walking, and affects older people. So we're going to expand on our knowledge about Parkinson's in the next hour. And these are my talk objectives. So, one, discuss the history of Parkinson's disease, review the motor symptoms of Parkinson's disease, review the non motor symptoms as well, discuss how Parkinson's disease is diagnosed, and discuss general management strategies for Parkinson's disease. So, let's start with the numbers. Parkinson's disease, or PD, is the second most common neurodegenerative disease after Alzheimer's disease. Affects 1 million people in the US, and this number expected to rise to 1.2 million by 2030, which actually is not that far away. It's in about 5 years. Nearly 90,000 patients are diagnosed with Parkinson's disease every year in the US, and globally affects more than 10 million people worldwide. In terms of the incidence of Parkinson's, it increases with age. So, most commonly, my patient population are ages 65 and older. However, Parkinson's can actually occur in younger ages, and we call that young onset PD or YOPD. So, I have several patients who are probably in their 30s to 40s when they first come in for their diagnosis. Men are about 1.5 times as more likely to develop Parkinson's disease compared to women. And for ethnic breakdown, it's most common in white individuals, followed by Hispanic, Asian, Black, and then Native American individuals. So the Parkinson's Foundation did this Parkinson's prevalence project, and it looked at how many people have Parkinson's disease throughout the US. And they noted that there were higher incidences in certain parts of the US, including the Rust Belt, which are parts of the Northwest and Midwest US, previously regulated by industrial manufacturing. There's also higher rates in Southern California, Southeastern Texas, Central Pennsylvania, and Florida. And we don't know exactly why. Is it because there are older populations there? People move there for retirement? But this is just the trends that have been seen in these types of studies. So, for Parkinson's disease, what are the most common risk factors? So, I work half of the time at the veterans hospitals here. And so I see patients who have certain military exposures, including Agent Orange from the Vietnam War, and also more recently, contaminated water from industrial solvents from Camp Lejeune. I also see potentially patients with pesticide exposure histories and also well water exposure, kind of related to the pesticides, and then heavy metal exposures. But these are not common overall. For the most part, see military exposures at the Veterans Hospital. Genetics actually accounts for a small percentage of Parkinson's disease patients, at most about 10 to 15%. And lastly, head trauma does increase your risk for Parkinson's disease. So, next question: who is Parkinson's disease named after? So, this is Dr. James Parkinson. He was an English physician who first described the motor symptoms of Parkinson's disease. And he published his findings in a paper in 1817 called An Essay on a Shaking Palsy. And what he did is he described 6 men with similar symptoms. 3 were his actual patients, 2 he met on the street, and 1 he just observed from a distance. And what did he describe? I write a little clip here. Involuntary tremulous motion with lessened muscular power, in parts not in action and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace, the senses and intellects being uninjured. And here I highlight some key components of this description: the tremors, the lessened muscular power, the propensity to bend the trunk forward, and to move from this walking to running pace. So even though he described this disease, he never attached his own name to the disease. So in 1872, about half a century after his death, a renowned French neurologist named Jean-Martin Charcot found his essay, read it, and understood its importance. And so he referred to the disease as Les maladies de Parkinson, pardon my poor French, and the name has since stuck. So he highlighted it again in his description, the four cardinal features of Parkinson's disease, the four cardinal motor features of Parkinson's disease, to be specific. And they are tremors, rigidity, slowness, and there's fancy words for that, akinesia and bradykinesia, which I'll talk about later, and then postural changes. For the tremors, rigidity, and slowness, of note, they tend to start on one side of the body and over time progress to the other side as well. And the way to remember these four cardinal features for motor symptoms is the word TRAP, T-R-A-P. So we're going to go through all of these symptoms, and I have some videos to show you as well. So T stands for tremors, and this is a rhythmic shaking. It can happen in your legs, in your arms, sometimes in your chin and jaw. And again, the tremors in your arms and legs tend to start on one side of the body. Sometimes it's called a pill rolling tremor. And importantly, it starts off as a resting tremor. So I often ask patients, when you're watching TV, does your hand shake? When you're distracted, at nighttime, when you're trying to fall asleep, does your hand shake? And they might notice, yeah, I didn't realize I had a tremor, but someone told me, hey, your hand shakes when you're watching TV. So now we're going to go into the video. Hopefully there's not much of a lag. We tested it before. So here we go.
Leave it on your lap, but make a fist. Kind of relax it, open up again. Kind of quick it up. Leave it on your lap again.
So that's one clip of a very classic Parkinson's disease tremor. Again, tends to be resting. So again, when it's relaxed in your lap, it will shake. Again, might have this pill rolling quality to it. You also might have an action and postural tremor, but the rest tremor is usually what starts that tremor. This is another video of Parkinson's tremor. This is actually Brian Grant, who is a former Portland Trailblazer basketball player. And he has a good amount of tremor in his arms, as you can see when he's talking.
Going on my 11th year in the NBA, so I just figured I was getting older and I was banged up and beat up. 2005 with the Lakers, definitely couldn't jump off my left leg like I used to be able to. 2006, now I have a skin tremor. Go to our neurologist, they tell me.
So for me, patients come in with a tremor. And I'll usually refer from their primary care doctor. The most common other tremor disease that I have to clarify if they have that tremor or Parkinson's disease tremor is essential tremor. And that's a disease that only has tremor. There's no other symptoms. It happens when you're young, it happens when you're older, and it tends to be more of an action posture tremor and affects things like eating, drinking, writing. So I just wanted to kind of show you what that tremor looks like.
All right. Yeah, but by the time that door started, and in my head, do bounce.
Yeah.
We said your lifestyle, that thought out.
Okay. Can you make a circle?
You'll see he's gonna try and write, and his pen is all over the place on the paper. Hard to hold steady. So that is essential tremor. That's usually what I have to clarify if they have essential tremor or Parkinson's disease when these patients come with a tremor evaluation. So that's T for tremors. R stands for rigidity or stiffness, and we can feel this in people's arms, legs, and neck. Um, Sometimes it can be hard to know the stiffness is due to arthritis, which of course is more common as you get older. So patients often will be sent first to a bone or joint doctor, like an orthopedic physician, before coming to me to get the evaluation for Parkinson's disease. There's a component of the rigidity that's a bit unique. It's called cog-wheeling rigidity, and I'll show you a video of it the next slide. But there's a ratchety component when you're trying to move your arms and legs. So I hope you can recognize that it was not a smooth movement with the wrist, that it was a very ratchety kind of cogwheel stiffness going on. So next up is A, and A stands for akinesia, which is a fancy Latin word for loss of movement. In clinic, we might also use the word bradykinesia, and brady means slow, kinesia means movement, and so patients have slowed movements. And slow movements or loss of movements can present in many different ways. So one of them is smaller handwriting, and we use a fancy word micrographia to describe it. So micro meaning small, graphia meaning writing. People also may have decreased facial expressions and look like they have a masked face or poker face. People might drool more, and that's because they aren't swallowing their saliva as often, not because they're producing more saliva, but because they are swallowing less often, the saliva will run out of a person's mouth. Walking changes can happen. Shuffling is a very classic change in the walking, taking small steps, not picking up your feet, decreased arm swinging. Your voice can change, softer, more slurred. And patients might tell me they have difficulty with day to day tasks, like getting dressed, getting their arm into the sleeve of their jackets, brushing their teeth, shaving, combing their hair, washing their hair, and typing on the computer. So here is a picture of what happens with writing with Parkinson's disease. So on the left, on the top, is a person who has not taken their Parkinson's disease medication. It's very small. You can't even read it. This is classic micrographia. And then the person takes their medication. They're able to move more easily, and their writing that gets much bigger and legible. This one on the right is, again, another example of a person who hasn't taken their medication on the top, very small handwriting, and then their writing gets much bigger, much more fluid as after they take their medication. So next is a video about how we look at slowness of movement in the clinic. There's an actual scale that we use. It's called the Unified Parkinson's Disease Rating Scale, and it looks at how easily you can move your arms and legs. There's different tasks like finger tapping or hand open and closing, turning your wrist, your arm back and forth, tapping your toes, stomping your feet. And this is a video just of the finger tapping. And you'll notice that this gentleman moves more slowly on one side than the other side. Another component of this video is that you might notice he's not blinking his eyes as much. He has more of this flat faced expression.
Yeah, quite a little. Well, it's not very.
So pretty good on the right side. Nice and quick. You can cry it yourself. That's good. Not too slow. But then on the left side, you can see that he has more trouble. Some stating that.
Min. What? Oh, yeah, you're running quick. Check out. That.
Okay, so that's A for akinesia. Now the last one is P, and P stands for postural changes. So stoop posture, balance issues, increased risk for falls. And this video is of also that same rating scale. There's a part where you have to pull the patient backwards, which is my least favorite part of that study or that scale. So you pull them backwards, and if you take one or two steps, that is fine. But if you take more than two steps, that's when you have balance issues. You can see why I don't like doing that part of the test. And this video now shows the changes that can happen with a person's walking. So taking small steps, the shuffling walking, not swinging the arms, not picking up the feet.
These three patients show more significantly affected gait. They all have idiopathic Parkinson's disease. This first patient is probably the most affected. His stride length and arm swing are very decreased. There you can see this turning on block. He also had some slight freezing in that turn. The amount that his stride length is shortened and the festination interfere with his gait, making it difficult. Therefore, I would rate that a 2 on the UP.
So the gentleman who's narrating the video is talking about getting the scale and looking at the degree of walking difficulties that patient has. Again, small steps, some balance checks, decreased arm swing, not picking up the feet. So next question, why is my talk titled More Than Just a Tremor? So I want to allow people to know that Parkinson's disease is more than just a tremor because not all Parkinson's patients have tremors. So there's what we call tremor predominant Parkinson's disease, so people with tremors, but there's another form of Parkinson's called akinetic rigid Parkinson's disease. Akinetic again means loss of movement, rigid is again stiffness. So some people don't have tremors, they just have the stiffness and slowness of Parkinson's disease. Another reason why Parkinson's disease is more than just a tremor is that Parkinson's disease is composed of both motor symptoms and non-motor symptoms. So again, the motor symptoms were tremors, rigidity, akinesia or slowed or loss of movement, and then posture changes. But there is a whole list of non-motor symptoms that can be related to Parkinson's disease. And I list the most common ones that we talk about. One is loss of sense of smell, dream acting or REM sleep behavior disorder, constipation, bladder issues, fluctuating blood pressures, mood changes, depression and anxiety, psychosis, meaning seeing things or hearing things that are not there, and then cognitive changes. And I often describe Parkinson's disease as an iceberg. So above the surface are the symptoms that you can see. You can see your loved one with Parkinson's disease having tremors, potentially having stiffness, the slowness in their movements, the changes in their posture. But under the surface, there are many different symptoms that can be affected with Parkinson's disease. Again, the loss of sense of smell, sleep issues, constipation, bladder issues, blood pressure issues, mood, cognition, and psychosis. I'm not going to be able to talk about all of these because I only have 1 hour, but I'm going to talk about the top 3, and I'll tell you why. Because sometimes these are very early signs of Parkinson's disease, and we also call them prodromal symptoms. So these can happen years and years before the development of the motor symptoms. Again, the tremor, stiffness, slowness, posture changes. Loss of sense of smell is a common one. We often call it hyposmia or anosmia, and there are actual smell kits that you can get, often through the Michael J. Fox Foundation, to see if you have a loss of sense of smell. REM sleep behavior disorder is another potential early sign of Parkinson's. And this is acting out your dreams in a particular stage of sleep called REM sleep, not the band, but rapid eye movement. And then this stage of sleep, your eyes move a lot. That's why it's called rapid eye movement. But your body normally does not move at all. But for patients with REM sleep behavior disorder, they are moving a lot. They are acting their dreams out. They're punching, they're kicking. Unfortunately, sometimes the other person in bed, they might fall out of bed. So this could be an early sign of Parkinson's disease. And then another one that patients might develop is constipation. So next question, how is Parkinson's disease diagnosed? So most classically, Parkinson's disease is a clinical diagnosis, meaning we don't have a test for it. Like, diabetes, you get your A1C, your glucose levels. There's not a standard Parkinson's disease test. It's usually the judgment of someone like myself who has done training in neurology, training also in movement disorders, we make that diagnosis based on how you look on your exam, your prior medical history. But not every patient is textbook or clear cut. So if the diagnosis is not so clear, we might consider the next steps, including, of course, monitoring the physical exam. And I tell my patients that Parkinson's disease will declare itself at some point because it does progress and does change. So it'll be more clear over time if it's not so clear right now. Next, we could get further specialized imaging, get a skin biopsy, and then, if appropriate, start a trial of a Parkinson's disease medication. So what is the further imaging that we get? It is actually not usually an MRI of the brain. You would think that it has good detail in terms of the structures, but that's not the one that we usually go to. It is actually called the DAT scan, and we'll tell more about the DAT scan in the next few slides. So why we use the DAT scan bears the question, what changes happen in the brains of Parkinson's disease patients? So brains of Parkinson's disease patients show degeneration, brain loss, in the deeper parts of the brain involved in motor control, and we call this area the basal ganglia. There's a loss of brain cells that normally produce a very important chemical messenger called dopamine. And dopamine is what is necessary for one cell to communicate to another cell. So when you lose that messengers, the cells can't talk effectively, and that's why you develop the motor symptoms and other symptoms of Parkinson's disease. So this slide shows how there is a loss of dopamine-producing cells in the brains of Parkinson's disease patients. So one such area is called the substantia nigra, which means black substance in Latin. So in Parkinson's disease patients, there's a loss of dopamine-producing cells here. And these cells also normally produce a pigment that makes this area of the brain dark. So you can see here, this is a Parkinson's disease patient brain tissue. This area is very pale compared to the tissue of the patient without Parkinson's disease on the top. So, how do we detect dopamine deficiency, loss of dopamine cells in Parkinson's patients without actually needing to obtain brain tissue? So that's what the DAT scan can be helpful for. So it is specialized imaging that can show loss of dopamine producing cells in the brain. It uses a radioactive tracer and it's produced by GE and approved by the FDA since 2011. So the tracer is injected into the vein and travels to the brain. And it is typically taken up by cells in the basal ganglia that manage dopamine. The tracer is then detected and measured by a special scanner. And this is what the scan looks like. It looks nothing like an MRI if you've seen an MRI. There's no good detail of the brain, but it provides a lot of good information. So in Parkinson's patients, again, there's less cells to take up that tracer, that radioactive tracer, compared to patients without Parkinson's disease. So on the left is a normal scan, a person without Parkinson's. Plenty of cells in that area to take up the dye. So the area has these nice full-looking commas. Or a Parkinson's patient, again, there's less cell to take up the dye. And so the areas look different. They're smaller. They're more like these punctate periods. And so this can be very helpful when we're not exactly sure if a person has Parkinson's disease. So important points. I do not order these scans, the DAT scan, for patients who I look at your exam and say you have Parkinson's disease based on the tremors, the stiffness, the slowness, the postural changes, and other findings that I say support Parkinson's disease. Most commonly, I order it for the following two indications. So again, essential tremor. People shake when they're doing things with their hands, but sometimes they actually develop a rest tremor over time. And because they have tremors in their hands, they can't move their hands as well. Or they have arthritis in their hands and they can't move their hands as well. So it can get a bit muddy with these essential tremor patients. Have they now developed Parkinson's disease in addition to essential tremor? So in this type of patient, I might order the DAT scan. I also may order the scan for patients who look like they have Parkinson's disease, but happen to be on psychiatric medications that actually aim to block dopamine. And we call this drug induced Parkinsonism. So, again, this can be helpful because if it's because of their medications, I might recommend that their psychiatrist change the medications to ones that don't block dopamine as much. And so these are the two main reasons why I order a DAT scan. So a normal DAT scan suggests that a person may not have Parkinson's disease, but does not totally rule it out as a possibility because it could also be early on in disease. These are not perfect scans. A positive abnormal DAT scan can help support a diagnosis of Parkinson's disease. This scan, however, is not able to differentiate between classic Parkinson's disease and other more complex, atypical Parkinson like diseases. And I can't describe these in detail because of the limitations of the talk, but they include progressive supranuclear palsy, multiple system atrophy, and cortical basal degeneration. Another component of that scan is that it actually can be abnormal based on what you're taking as a medication. So, certain medications can impact how well that tracer gets taken up by the brain cells, causing the DAT scan to look abnormal. And the most common offender is bupropion, which is a commonly used antidepressant. I've had patients that were referred to me for Parkinson's disease because they had that abnormal DAT scan, but happened to have been on bupropion during the scan. So I have them stop it for a full 8 days. That is what is recommended by GE. Repeat the scan, and the scan is normal. So just keep that in mind if you are one who is going to get a DAT scan or has gotten a DAT scan. And sometimes you will get the DAT scan and the actual report says it's inconclusive. So then what? So brains of Parkinson's disease patients also show accumulation of a protein called alpha-synuclein. And alpha-synuclein accumulations are called Lewy bodies.
Wow.
So this was named after Dr. Frederick Lewy, who is a German neurologist who described them in 1912. Parkinson's disease, is sometimes thus called a Lewy body disorder. So you might have heard of that or read about that Lewy body disorder. And this is a schematic of what it looks like. Basically, there's abnormal accumulation of alpha-synuclein, building bigger and bigger structures into a Lewy body, and that affects the function of the cells in the brain. And these are two cells in the brain one that shows a Lewy body. So the one on the bottom right has this round structure, and that's a Lewy body. On the left is a normal cell that does not have a Lewy body. So it's not realistic, of course, to get a brain biopsy to look for Lewy bodies or alpha-synuclein accumulation. However, now nerves of Parkinson's disease patient skin can actually show accumulation of alpha-synuclein. And there are now commercially available skin biopsy kits that can actually identify abnormal amounts of alpha-synuclein in skin nerves. So the SYN1 skin biopsy is the one that we use currently. It's manufactured by CND Life Sciences. It's an outpatient office procedure. It involves 3 punch biopsies, one in the upper back, one in the lower thigh, and one in the lower leg. Very easy to do. I do them on occasion in my clinic as well. And what the company does is it basically stains the tissue for markers of brain cells and then also stains it for accumulated alpha-synuclein and puts it on top of each other, overlays it. And if there is accumulated alpha-synuclein, this supports that a person has a synucleinopathy. There's abnormal accumulation of alpha-synuclein in their cells. So I've gone through how we diagnose Parkinson's. We talk about it being mostly a clinical diagnosis. And if it's not so clear, we use, again, exam monitoring, further specialized imaging with the DAT scan, consider a skin biopsy. And in certain patients who may not want to do further imaging or get a skin biopsy, we often will do a trial of a Parkinson's disease medication. Because if they do have Parkinson's disease, the expectation is that their symptoms get better with a medication. So then the next question is, what treatments are available for Parkinson's disease? Unfortunately, we do not have a cure currently available. However, we do have several medications that are able to treat both the motor and non-motor symptoms fairly effectively. The general goals of our treatment. So we can't cure Parkinson's, but we can aim to maintain mobility, cognition, mood, swallowing ability, sleep quality, independence, and just overall quality of life. So how again do we treat Parkinson's patients? Remember again that Parkinson's patients have a dopamine deficiency. There's not as much of that chemical messenger to allow for communication between cells. So Parkinson's disease, deficiency in dopamine. Thus, medications aim to provide dopamine and increase its availability and longevity in the brain. And increasing dopamine levels can help with tremors, stiffness, slowness of movement. It may or may not improve posture or balance issues. So how do we increase dopamine? So there's three main different mechanisms. One, we give more dopamine. Two, we give a synthetic medication that works at the same location as dopamine. Three, we prevent dopamine from being broken down as readily, so it stays around longer to work longer. And these are the most common medications we use for these different mechanisms. So again, to give more dopamine, that's carbidopa, levodopa. The synthetic medication that works at the same location as dopamine is ropinirole or pramipexole. And the medication to prevent the breakdown of dopamine is most commonly rasagiline or selegiline. So I, again, don't have enough time in this talk to talk about the many different medications we have for Parkinson's disease, but I will highlight our gold standard medication, and that is carbidopa levodopa, also known as Sinemet, which is the brand name. So again, this is our gold standard medication for Parkinson's patients. I will say most patients have been on a trial of it at least some point in their disease course. It has two components, which is why it's impossibly hard to say, especially multiple times a day. So carbidopa, levodopa. So one part is carbidopa, one part is levodopa. So the levodopa, that is the precursor. It becomes activated to dopamine. Carbidopa prevents levodopa from being activated to dopamine until it gets to the brain. Because if it gets activated before it gets to the brain, for instance, in your gut, it can cause a lot of GI upset, nausea, vomiting. So together, carbidopa levodopa maximizes getting dopamine into the brain and limiting side effects, again, such as nausea. Generally speaking, brand names make zero sense. They're very long and hard to say, but this is the one brand name that actually makes sense. So Sinemet, if you think about Latin, sin means without. Emet is Latin for emesis or vomiting. So Sinemet means without emesis or without vomiting. So I thought that was a very creative brand name and actually fairly easy to say. There are different formulations of carbidopa levodopa, including immediate release and controlled release tablets. There's also special capsules that have both immediate release and controlled release beads. Generally speaking, this medication is best taken without protein because it impacts its delivery into the brain. Carbidopa levodopa doesn't just kind of migrate straight into your brain. It gets transported by a special a special transporter that also transports protein products. So in the Seattle area, I use the ferry analogy. So the medication and protein products are competing to get onto the ferry to get into your brain. So to maximize your medication getting to brain, you want to limit your protein so all the medication can get on board onto the ferry and into your brain. The most common side effects are drowsiness, lightheadedness, because it can drop your blood pressures, and nausea. So I treat Parkinson's beyond medication. I would say in the typical visit, I talk for several minutes on your medication, but I talk at length about lifestyle adjustments, changes, including regular exercising. This is so important. There's so many studies that show that regular exercising slows the progression of Parkinson's disease. And there are many different ways to exercise. You can do in person, you can do online classes. If a person needs the expertise of particular therapists, I have them see a physical therapist. If they're having any swallowing issues or speech issues or thinking issues, I have them see a speech therapist. Or difficulty with day-to-day life activities, I will refer to occupational therapy. I also talk at length about support groups, maintaining good mental health, and I tell my patients that stress worsens Parkinson's disease. So whatever you can do to reduce stress, and if that includes getting a therapist, optimizing your mental health, do it. And supportive treatments like massage, acupuncture can be quite helpful. And here I highlight two important physical therapy and speech therapy programs that are specialized for Parkinson's patients. There's the Parkinson Wellness Recovery, which is a specialized PT or a physical therapy program. There's LSVT Loud and Big, which is Lee Silverman voice training, and that focuses on speech and movement for Parkinson's patients. And I think there are some questions about online resources. The links will be all on the website. And I'm going to go in a bit more detail about the wonderful online resources we have, highlighting the American Parkinson's Disease Association, the Northwest Parkinson's Foundation, and the Parkinson's Foundation. So for the American Parkinson's Disease Association, or APDA, this is basically what they have on a regular basis, online, free. So there's high intensity exercise regimens, there's dance, there's singing, there's chair exercises, there's yoga, and they're all free many times a week. So really utilize these free, wonderful resources. The next one is Northwest Parkinson's Foundation, which offers both in-person and online resources and exercise classes. They have rock climbing, they have Zumba, singing, biking, which is a very popular Parkinson's sport, and then also rock steady boxing. And I'll show a video what that is in the next couple slides. And then the Parkinson's Foundation has this wonderful Fitness Friday, and they have many classes. I just took a clip of a couple of them. They have yoga, voice, strengthening cardio, boxing. So really, again, these are some wonderful resources for you or your loved one who has Parkinson's disease. And so here's a quick clip about rock steady boxing, which is very popular with my Parkinson's patients.
Come on, Aaron.
That's my husband, Aaron Latham,
Come on.
with his boxing coach. He and everyone else in the class has Parkinson's.
Give me all you got. Come on.
Come on. Boom, boom.
It's a progressive neurological disorder that affects nearly 1 million Americans. You don't hear about very many with the disease getting better.
I think of Parkinson's as being an incredible shrinking disease. It doesn't shrink itself. Parkinson's doesn't shrink. Parkinson's shrinks you.
And I want you to reach up.
Aaron and his fellow Parkinsonians, aged 45 to 92, are part of this new program that aims to stop the shrinking, if not reverse it.
Together.
Each exercise works on a symptom.
Go up. Come on. Give me 10. Up.
Stretching is for their stiffness. Footwork for balance.
Ready? Boom. Come on.
Punching to steady their tremors.
Boom. Yes.
Go. Ah.
Shouting to counter their soft voice syndrome.
The video is much longer. Feel free to Google on YouTube, like Rock City Boxing. You'll find some great videos about what Rock City Boxing can offer. So next question. Now that I'm diagnosed with Parkinson's disease, what should I expect? So when people ask me about prognosis, I mentioned to them that Parkinson's disease has probably been acting in several years before you come to see me. So there's the premotor prodromal period. So that's maybe 10, 20 years before you come and see me because you develop a tremor or stiffness or slowness. This is again those the prodromal symptoms like decreased sense of smell, REM sleep behavior disorder, constipation. Then you develop the motor symptoms, and now you're on medications, different treatments for Parkinson's disease. I will say, generally speaking, the first 5 to 10 years are generally more or less predictable, slower going. And then when you hit the 10-year mark, that's when things can progress more rapidly. So this is, again, what I usually say when people ask me, how should I expect the next 5 to 10 years or beyond that to go? With advancing Parkinson's disease, generally medications work fairly well in the first several years of Parkinson's motor symptoms. So, also engaging therapy support can help maintain mobility and independence. But however, over time, medications can be less reliable, symptom control can fluctuate, and side effects can be more bothersome. And the more common one is dyskinesias, which are wiggly, abnormal, kind of excessive looking movements. And I have a video of this in the next slides. So again, with motor fluctuations, initially in early Parkinson's disease, you take your medications a couple times a day and you have, generally speaking, good symptom control. As the disease progresses, you might have to take your medications more often, and you might see the highs and lows associated with your medication. When you take it, maybe you move too much with the dyskinesias. Sometimes when you take it or you don't take it as often, you feel the lows, like you can't move. So we often use the on-off phenomenon to describe how you feel. When you're on, that means you can move well and do day-to-day activities well. When you're off, you just feel like you're a statue. You can't move. You can't control your body well. And this gets harder and harder as Parkinson's progresses. Here's just a brief clip about Michael J. Fox, who has had Parkinson's disease at least since he was in his late 20s. So he's had Parkinson's for more than 30 years. And so he's dealt with the highs and lows of Parkinson's disease, and he has been on medications for quite a while and has thus developed dyskinesias, which again are those kind of wiggly, uncontrolled, restless looking movements.
What did you know about Parkinson's?
Somebody's grandmother had it. I mean, it was not a thing that I noticed or thought about. It really entered in my world. I was a 29-year-old guy.
Did doc-
So again, those wiggly movements are dyskinesias. A lot of times patients are not bothered by them, and so I may not adjust their medications or add medications to treat them, but they are a fairly common side effect of the carbidopa-levodopa over time. Importantly, I emphasize to my Parkinson's patients that everyone is kind of a snowflake. I see a lot of Parkinson's patients every day, and everyone is just a little bit different. They're at a different age, different stage of their life. They have different medical issues. They have different lifestyles, and everyone's progression is just a little different. So I treat every patient on a case-by-case basis with regards to their medications, with regards to all the treatment that they might have, including therapy, like speech, physical therapy, or occupational therapy, if I engage in anything else in terms of mental health or massage or acupuncture. So everyone is unique and everyone's treatment plan is unique. So next question, are there any treatments beyond medications? So I highlight 3, and I know the third one actually is a medication. I was thinking about that later as I was developing the slides, but I would say it's a bit more unique delivery of a medication. So the ones I'm going to talk about are the deep brain stimulator, or DBS, focused ultrasound, and then subcutaneous carbidopa-levodopa. So DBS, or deep brain stimulator, this is the most frequently performed surgery for Parkinson's disease. It has been FDA approved for Parkinson's since 1997, so quite a while. It consists of implanted electrodes in the brain connected to a stimulation device that looks like a pacemaker in the chest. And so myself and other movement disorder specialists, basically we use a programmer. So it's either like a Samsung tablet or a Microsoft, what do you call it? The tablets or the laptop. And basically, we program different stimulation fields in the brain and adjust these stimulation fields as needed to reduce Parkinson's motor features. It can be very helpful for treatment-resistant tremors. So tremors where you increase and increase the medication, but that tremor is still stubborn and won't stop shaking. It can be very effective for tremors. It can be effective for motor fluctuations. So none of the highs and lows of your day-to-day symptom control. And it can potentially reduce medication burden. So some patients have to take their medications every 2 to 3 hours. We can definitely dial that back with the deep brain stimulator. And this is what it generally looks like, the setup. So you have your electrodes that are implanted in certain parts of the brain. It's connected by a wire that's tunneled under the skin, so you don't see it. And then it's connected to a generator in the chest. And there are several companies now that are available with deep brain stimulator technology. One of them is Medtronic, which is the picture on the bottom. And then the one on top is Boston Scientific. And those are the main companies that we use here at University of Washington. And again, they have different components to them. They have their electrodes, which are about the size of a wire you hang pictures with. So just to give you a frame of reference of how big they are. And then these are the generators that sit in the chest. And then the smaller devices are your own programmer where you can increase or decrease your stimulation. And then the biggest programmer is what we use in clinic to basically program these stimulation fields in your brain. So next is focused ultrasound. And this uses beams of ultrasound waves with MRI guidance to cause purposely a lesion in the brain. So this was previously approved by the FDA to treat many different things like bone cancer, fibroids, prostate cancer, and also essential tremors. In 2018, tremor predominant Parkinson's disease was also added as a FDA approved indication. And this is what the setup looked like. It uses the MRI to guide where the beams are focused onto. And you wear this unique silicone helmet to keep your head from getting too hot. And the last one, which technically is a medication, but a very different delivery of the medication, is subcutaneous carbidopa-levodopa. This was just recently FDA approved as of October of 2024. So it is subcutaneous carbidopa-levodopa called foscarbidopa, if you want to get it even more tongue twisting. It is administered via a pump 24 hours a day. So what it aims to do, it aims to reduce motor fluctuations and those extra wiggly movements, the dyskinesias. It aims to improve medication delivery by bypassing the gut because you take your pills and you feel a lot of constipation or gut issues, those medications don't get absorbed effectively. And this is generally what it looks like. You have your pump that is connected to a cannula. It's a plastic cannula that you put into different areas of your abdomen. And ideally, again, it's aiming to give you a very, very smooth amount of carbidopa-levodopa throughout your day. We haven't used them yet. It literally just got approved a couple weeks ago. And so going through insurance companies now to get it approved and available for our patients. So I do hope that it helps with the right patient population. And so that's why I bring it up today in this talk. Okay, so last question. We're almost at the end of the talk. What research is being done for Parkinson's disease? So there are many different aims of Parkinson's research. One aim is to understand more about Parkinson's disease. There's so much that we still don't know about it. For one, we do not have a good biomarker. We don't have a way to identify patients early on with Parkinson's disease. We don't have a way to track how disease progresses. We don't have a great way to track how you respond to potential disease-modifying therapies. So biomarkers that are being developed are ones that focus on alpha-synuclein accumulation, changes in your imaging, and then digital biomarkers, subtle changes in your speech, subtle changes in your walk. The most prominent group that is studying biomarkers is the Parkinson's Progressive Markers Initiative, or PPMI, which is funded by the Michael J. Fox Foundation. Another way we are aiming to learn more about Parkinson's disease is understanding more about genetics. So we know a bit about the genetic causes, but we don't know a lot about the genetic causes of different ethnic groups. And so there are a lot of studies looking into the variances of genetics in the different ethnic groups. One of them is GP-DO, one of them is PD generation, that's funded by the Parkinson's Foundation. And one of them is VET-PD, which is more centered on the veterans population and is a subset of GP2. And then another big aim is to develop disease-modifying therapies. So aiming to reduce abnormal alpha-synuclein accumulation, reducing oxidative stress that can damage the brain, reduce inflammation that can damage the brain, and looking more into those genetic mutations and seeing if we treat those genetic mutations, can we treat Parkinson's disease? So these are good research resources if that is something you're wanting more information on. So you can look at the Michael J. Fox Foundation because they fund so much of Parkinson's research. There's also the Washington State Parkinson's Disease Registry, which can connect you to the different studies in the area that are aiming to treat Parkinson's disease patients. Okay, so we are on to our take-home points. I think there are some true or false questions that I think could be answered with these last two slides. So Parkinson's disease is a neurodegenerative disease that more commonly affects the older population, but can also affect younger individuals as well. Parkinson's symptoms include both motor symptoms, so that's tremor, stiffness, slowness, postural changes, and it also includes multiple non-motor symptoms. Not everyone with Parkinson's disease will have a tremor. Again, there is the akinetic rigid type of Parkinson's, in which you mostly have stiffness and slowness. Parkinson's disease is typically diagnosed clinically by someone like myself, but in uncertain cases, we might utilize specialized imaging like the DAT scan or the skin biopsy. Parkinson's disease causes loss of dopamine-producing brain cells. Parkinson's disease brains show abnormal accumulation of alpha-synuclein, and we call these Lewy bodies. So Parkinson's is a Lewy body disorder. Parkinson's medications increase dopamine levels in the brain, and this helps with, again, the motor symptoms of Parkinson's disease. Exercising is so important for Parkinson's patients. Again, I talk at length about exercise with pretty much every one of my Parkinson's patients. For procedures that can help with Parkinson's symptoms, that includes the deep brain stimulator, or DBS. This is the most common surgical treatment for Parkinson's disease patients. There is currently no cure for Parkinson's, but there is a lot of research currently being done to understand more about the disease and how to modify its course and protect the brain. And again, these are some great resources to learn more about Parkinson's disease, to get involved, be in support groups, exercise classes. There, again, the APDA, the American Parkinson's Disease Association, the Northwest Parkinson's Foundation, the Parkinson's Foundation, Davis Finney Foundation, and then the Michael J. Fox Foundation. And all these links will be online associated with this talk. So this is my last slide. I was trying to figure out a way to provide inspiration at the end of this talk, and I point to this particular organization. It's called Pass to Pass. So these are Parkinson's patients who go on these amazing hikes in the summer, maybe even not in the summer. They go to hikes all throughout Washington State, California, and all levels of Parkinson's patients are welcome. Parkinson's supporters are welcome. For patients who can't hold a heavy pack, they have llamas who carry your stuff for you. It's amazing. So I just want to end this note to inspire you to keep moving if you have Parkinson's disease, if you have a loved one with Parkinson's disease. And that's it.
Thank you again.